Antonis, you want to proceed with the next case? Dr. Rúskας?
I don't have the agenda in front of me, so maybe you introduce the next one.
Okay.
Thank you.
Dr. Rúskας.
Καλημέρα.
Try
Good morning.
10 to 15 minutes,
Okay.
no more.
I'll try to be as quick as possible.
Another representative for cardiomyopathy.
Yeah.
Good.
So, after two interesting cases with HCM, we go back to a classic HCM, I could say, dilemma. And the story begins with a young patient, a 20 years old male, who was a soccer athlete and who could have 4 training sessions every week and 1 game as well. So he came for a sports participation screening with not known family history of cardiomyopathy, being asymptomatic and in the New York Heart Association Class 1. And when we go to his ECG, which is in sinus rhythm, we could say an incomplete RBBB, the most important finding is that we have a diffuse ST depression in the inferior and anterolateral leads of the ST segment, as well as a negative T-wave finding, which is quite profound. And when we go to his echo, we can see that there is an asymmetrical hypertrophy of the left ventricle, which can be seen for both the parasternal long and short axis. The systolic function of the left ventricle is normal. Whereas when we go to his CMR, we can see the hypertrophied intraventricular septum, especially in the base anterior, basal anterior septum and basal mid-inferior septum. And in terms of the late gadolinium enhancement, one moment, please. Okay, thank you. So if we go to his late gadolinium enhancement technique, we can see that there is only a mild enhancement and some kind of mild heterogeneous signal in the septum, as you can see over here mostly, and especially in the, let's say, short axis over here, which means that it would be a finding of ongoing fibrosis for this patient in a very, very early period, let's say. The holder did not show any non-sustained VT episodes or any VPC burden, and the genetic testing showed a likely pathogenic variant for troponin T2 gene, as you can see here. And of course, we have to do the risk stratification scores afterwards. So if we go to the European HCM risk score on the left part of the slide, we can see that the risk is very low with a not indicated ICD. And as for the younger, I can say that this is the answer we need to put in to get this score. So it's the age, the maximum alveolar wall thickness, the left atrial size, the LVOT gradient, the family history of sudden cardiac death, no sustained VT and unexplained syncope. Whereas when we go to the 2020 guidelines from the other part of the Atlantic, there's no major risk factors, as you can see here, or any more non-sustained VT or any extensive amount of LGE. So we started screening the family of this young male. The father was asymptomatic with a normal ECG, with normal echo findings, and a negative genetic test. Whereas when we go to the brother of the proband, the 60 years old, he was also symptomatic with no other medical history, and an ECG which seems normal to me, and the genetic test was again positive for this specific mutation, so a carrier of this specific mutation. And then the last person to be screened easily, let's say, from the family was the mother, who was a 52 years old at that time, being also asymptomatic. He could not say any sorts of breath or any dizziness or any palpitation or any episodes of syncope. And when we see the ECG very carefully, let's say. It is on sinus rhythm, but we could say that there is some kind of mild ST depression, again in the inferior and inferolateral leads, with somehow flat or slightly negative the T waves. So it looks somehow, but not exactly the same with the ECG of her son. And when we did the echo, we could see again asymmetrical hypertrophy of the left ventricle, as you can see here in both long and short axis. But we can see that it looks like there's a little bit of bilateral enlargement as well, as you can see here from the LA and the RA. Whereas when we go to the Doppler technique, we can see from the mitral valve diastolic filling pattern that there is some kind of pseudo-normalization pattern, with the wave being more than A, as you can see here. And as I forgot to say that the maximum wall thickness was measured up to only to 15 millimeters. And when we check the right ventricular systolic pressure, it looks high, so about 50 millimeters per mercury. And when we go to the tissue Doppler, interestingly, the E to E prime ratio is high as well. So it was estimated as being 13. The next step would be for us to do an MRI. So we look at left ventricle with a normal systolic function, a hypertrophied, mildly hypertrophied intraventricular septum, as you can see here. But when we go to the LG technique, we can see that there is hazy patchy enhancement, especially at the mid-wall basal, mid-anterior IVS, as you can see clearly here, over here, and over here as well. And this LGE was estimated as being, the fibrosis was estimated as being of the 9.5% of LV mass. Holden did not show anything significant, just a few ectopies, ventricular and atrial. And when we did the genetic test, again, it was positive for this specific mutation on the troponin T2 gene. Looking at the right part of the slide, we can see the family tree of the family. So, getting a summarize, we have here the proband, the brother who is just a carrier, and the mother who has both the genotype and phenotype positive. But going back to the history, the sister of the mother died suddenly. She had a sudden cardiac death, being only 7 years old, with a not known history of cardiomyopathy. And when we did the risk stratification scores from both Europe and from the American guidelines, as you can see on the left part, the risk was only 1.95%, and with not an indication generally for the ICD, bringing all the answers as we have told for the son. Whereas when we take the guidelines from the American Heart Association, we could say that there is a major sudden cardiac death risk factor, which is the family history for sudden cardiac death. And that's the main question to the floor and to the chest, of course. Is ICD insertion indicated? That's the main issue, as you can imagine. Going back to the pathophysiology and make things clearer, we can see the sarcomere here and bone the thin and the thick filament. And troponin T is part of the troponin complex as well, with the troponin I and troponin C. And so the troponin T binds the tropomyosin with the troponin complex, adding this to actin. So in a relaxation, we have an installation of binding actin with myosin. So in terms of epidemiology, the troponin T2 cardiomyopathy, we know from the literature that HCM affects about 1 in 500 old dudes, with the majority of cases being familial, falling most of the times in autosomal dominant pattern of inheritance, with 4% of the case of HCM to be attributed to these specific mutations, whereas in the family HCM history, 50% seem to come from mutations from the troponin T2 gene. About 30 distinct pathogenic or likely pathogenic varieties have been associated with HCM, with even mutations, as we can see later on, will be met exclusively within families. A recent meta-analysis from Macha a few days ago, it will say that the penetrance of TNT2 in familial HCM is with a median diagnosis of 36 years old is about 62%. So in terms of prognosis, the main paper that started the whole, let's say, history of this specific hypertrophic cardiomyopathy was back in 1995, with the main conclusion that even patients with mild or minimal hypertrophy on the left ventricle could have sudden cardiac deaths. But this we think it may have changed through the years, as we will see afterwards. In terms of experiments, I showing this paper from only a few years ago, just to show how arrhythmiogenesis could be caused, starting with fibroblasts and stem cells, entering with this specific technique, as the Dr. Viveri said us yesterday, these specific mutations. So we created somehow these specific cardiomyocytes, and that would cause like a sensitization of the calcium in the myofilament, and this could cause both diastolic dysfunction, action potential deregulation, and disarray in the microfibers, and this would increase the arrhythmia risk. This paper from 2012, which is from the UK, included 552 unrelated probams with HCM. 92 of them carried TNT2 mutations, both probands and relatives, with a mean follow-up of 10 years. We can see especially about 2/3 of them would have both an echo and ECG with findings. Normal ECG would be most of the times normal as well as the echo in the first 10 years of the life of the patients. Where in terms of the Kaplan-Meier variant analysis, we could say that sudden death, with the annual rates of sudden death for both from the childbirth and during the follow-up was very low. As we go further to the different mutations from the same paper, we can see some specific mutations come earlier and with a worse prognosis. So the one with the red arrows would show that these patients would have, in an earlier age, even sudden deaths, as compared to other mutations, as we will see later in the presentation. Somehow the same comes back to us in 2016 from Spain. So about 150 HCM probands, with 10% being of them with troponin T2 gene positive. So what did this paper show to us? That this specific mutation would cause more sudden deaths compared to none without this specific mutation inside the gene, in the specific gene, or even compared with other genes, even if we would not identify the mutations. This paper compares thin filament HCM patients versus thick filament HCM patients, 80 versus 150, with 50% of the mutations being on troponin T, with a follow-up of 4.5 years. And we can see clearly on the left side of the diagram that the thin filament HCM patient would most of the time have more diastolic dysfunction, more pattern of triphasic LV filling with L waves, less obstruction, more extensive fibrosis, and the adverse mode would be most of restricted evolution. I think that even the mother of the patient could evolve some time of this kind of phenotype long term. Comparing troponin T with the other troponin genes, we can say that troponin C comes earlier in our patients, and it seems to have even more events of sudden cardiac death and ventricular fibrillation, as you can see here. Many papers exist about arterial myopathy in troponin T HCM. So there's quite a lot of literature and experiments going on that say to us that even different mutations could cause a different burden of atrial fibrillation, and even specific mutations either this is sporadic or this one, which is quite variant, would do different kind of remodeling in the left atrium, and that would cause us, let's say, different ways of treating these patients according to the genotype form. We know from the guidelines that troponin 2 does not exist only in HCM patients, but also in DCM patients, and that was reported even from back in 2000, and even in restrictive cardiomyopathy patients from back to 2006. And interestingly, we can see even inside the same family, with the same specific mutation, as you can see over here, all the carriers of mutations are phenotype positive, but they could have even different expression, with 9 of them being at all. So all the carriers of the gene would have some kind of cardiomyopathy, where non-carriers would not have any cardiomyopathy. So HCM, RCM, DCM, mixed cardiomyopathy, and mild concentric LVH, and all of this would go to a restrictive pattern of left ventricle. So many thanks for hearing me.
Okay, well, fantastic presentation, Pavlos, again. Bill, that's your gene.
Thank you. So very nice. So you were showing survival comparisons between troponin and other genes, thick filament, thin filament. But the message that you said, the real message is that it's not comparing troponin to myosin. It's actually the specific mutation. So you showed different mutations. Your patient, I think, was alleles encoding amino acid 85. I don't remember that particular one, but my instincts are that is probably benign, looking at the family. And so why does that one patient die suddenly? And we don't know enough about that patient. Were there additional variants? But in general, there are very benign troponin T families, the 271, for instance. Nobody died, no females die suddenly, and the odd male. In contrast, if you've got alleles encoding amino acids 92 to 95, which one of your families was, and which I showed yesterday, 40 to 50% of males have died suddenly by the age of 45 or 50. So the specific mutation is the key. Now, if you go back, so that's one. If you go back to the risk, here we have a young athlete, and what do? If you showed the guidelines, and you showed the European approach, the risk profile, and the American guidelines. If you look at the European approach, what is missing from those? There's no gender, there's no mutation, and very importantly, there's no blood pressure, exercise blood pressure response. And if you read the paper, it says, oh, we've only taken specific features from multivariate analysis. The truth is, the strength of an abnormal blood pressure response in a young person is so much greater than anything in the multivariate. You can take a multivariate and you can remove the most important thing and get a statistic. The most important thing in this young man is his exercise blood pressure. And if his exercise blood pressure is flat, I would be worried and I'd consider an ICD. If it's not flat, I'm not sure I would change anything, including athletic participation with frequency. So his exercise blood pressure, the two things, the most sensitive is exercise blood pressure, the most specific marker is non-sustained VT, which he doesn't. So we haven't completed, and the European score is faulty. Why don't we have exercise blood pressure there? Because when we did it, we had reliable measurements. But when we had a validation cohort from European colleagues, we couldn't rely on the blood pressures. So we couldn't put them in. But it should be, that's something that I would do above and beyond the risk profile. The American ones, I would say, is even worse, because in the American guidelines, we had exercise blood pressure was there for more than 15 years as a risk. And all of a sudden, in the Almond guidelines, more recent, the 2020 or whatever they are, the blood pressure is just disappeared. The exercise test has disappeared. No comment, not debate, just disappeared. And yet it's the most sensitive marker in young patients. Why has it disappeared? If you work in a big place like Mayo Clinic, doing an exercise blood pressure, they do all their exercise tests in the same way. There's two protocols, one for ischemic heart disease, it's a Bruce protocol, the other is for heart failure, it's a modified, but they don't do the blood pressure. You can't just put a cuff on, an automatic cuff. So this has come out of the guidelines because it's not convenient to do for many reasons.
For Mayo Clinic.
I'm using Mayo as an example because they're a big center that are very good in every aspect, and they were influencing the guidelines because they were, for one the previous guidelines, there were 5 members from Mayo Clinic on the guidelines out of about 9, and their most recent, they were heavily influenced. So they are important, and they're a very high quality center. But I would just point out that the guidelines are guidelines. Have your own view about what these guidelines actually mean, because the other thing in the American guidelines is they've downgraded non-sustained VT as a marker. So I think for me, this young athlete, I do an exercise test, and it doesn't have to be VO2. Well, VO2 would be useful if you can, because again, if he may be, if he's less than 80% predicted, if he's got a flat blood pressure response, I would be worried. My instincts, he'll be fine.
Professor,
I agree with you. It's a risk marker for patients less than 40 years of age. The abnormal blood pressure response on exercise. I don't know what was the reason that this marker was retrieved by Europeans and Americans also. I don't know. And something else for you, Bill. Can you tell us if there are any other troponin T mutations carrying a high risk for sudden cardiac death, except the previous you referred?
So good question. I don't. Quick answer is I don't know, but there must be. And with the respect to this, if you give me the variant, I can look at the database because we've got, I don't know, maybe 500 troponin T variants on the database, and the 85 amino acid 85. I don't recognize that, but they're definitely very benign. 271, nobody dies. 92 to 95, very significant. We need to find out specifically about that mutation, which I can. So if you just give me the variant, I can email you back and say how number of patients and whether it's benign or not. We have survival curves on these patients.
Thank you.
Okay, I think we have to move on. Thank you, Pablos.